Hi, good evening, everyone. So, thank you for joining us tonight. I'll be joining myself, Mr. Jagwant Singh, and Mr. Alistair Jepson. We're all part of orthopedic specialists, an orthopedic and more group led by Ali Noorani, Professor Adrian Wilson, and Mr. Nima Hadari. We're based at HSSH, but also various locations around London, beyond London. For example, Mr. Jepson is working from Northampton, but also is available for consultations at more central locations as well. So as you can see from the website, there are multiple surgeons, including maxillofacial surgeons or pediatric consultants. We've got visiting surgeons from Belgium, like Professor Van Riet, and we also have pain consultants, rheumatologists, as well as sports medicine doctors. So I'd like to then introduce more formally Mr. Jagwant Singh, who is an upper limb surgeon specializing in all aspects of upper limb, including the hand and wrist. And he works out of the Lewisham Trust, the Greenwich Lewisham Trust at the moment. He's been highly trained through various leading centres, including centres in the US, and is now settled back down in London. He'll be starting off our presentations with a talk about trapeziectomy. I'll then follow, and my name's Onur Berber. I'm one of the consultants at the Royal Free London, specialising predominantly in hand and wrist problems. And then they'll be followed by Mr. Alistair Jepson, who is an experienced surgeon. I've been working for over close to 15 years on all problems associated with the upper limb. As mentioned earlier on, his base is in Northampton, but available beyond that area. Mr. Jepson will then be talking about CMC joint replacement, and that'll be closing off the evening. As Mr. Singh mentioned earlier on, if you don't mind sending us questions over the chat, we'll either try and answer them after each presentation, or maybe save them all for the final presentation, final point at the end. So I'd like to open up with Mr. Jagwant Singh. I'm going to stop sharing and allow Mr. Singh to take over.
Thanks, Onur. It says host disabled participant screen sharing.
So let's double check here. Participant, stop. New share, no.
Yeah, same again.
Same again, hold on. I'm going to stop sharing. Does that give you the opportunity to then connect?
No, it says host disabled participant screen sharing.
Okay, my mistake. That should be available to you now.
Okay. Can you see that now?
Yes, we can. Thank you, Mr. Singh.
Okay, good evening, everyone. Thank you, Onur, for the introduction. So I'm going to make a start today with basic anatomy of the first CMC joint and what managements we do offer at the initial stages of the problem, and then later on. My colleagues will be talking about the new developments, the recent innovations, and arthroscopic and joint replacement management. So when we look at the thumb joint, it's the workhorse of the hand. Nearly 80 to 90% of the hand function is grip and grasp, and that is where the thumb is an integral part. Women can say that they work harder than men, and that's why they get arthritis, but it is related to the specific kind of activities they do, which predisposes them more to arthritis. When we look at the anatomy of the first CMC joint, it is a double saddle bony articulation. The joint is relatively incongruent and semi-constrained. And that allows it the versatility of movements in different planes, the abduction, the adduction, flexion, extension, and then comprehensive movements, which are lateral rotation, opposition. the thumb joint does rely on the static stabilizing structures as it lacks bony confinement. It's, as I mentioned, relatively incongruent and semi-constrained. So the different ligaments which we see here, the most important one is the anterior oblique or the beak ligament. And when we see incompetence of the beak ligament, that's where there is subluxation and more stresses and strains across the first CMC joint, which predisposes it to more arthritis. So when we have the competence of the anterior oblique ligament, we have deforming forces in the abductor pollicis longus and adductor pollicis. Now this would lead to an adduction deformity, and the metacarpophalangeal joint will extend so as to compensate for this. And this is the Z deformity, which we see in the patients who present with advanced first CMCJ arthritis. Now, there's this Eaton and Little grading, which is widely used. Stage 1 is a pre-arthritic stage. There's widening of the joint space. The stage 2 is when there is slight narrowing of the CMC joint with osteophytes less than 2 millimeter. More than 2 millimeter osteophytes and marked narrowing is the stage 3, while as pantrapezial arthritis is the stage 4 of the Eaton-Little classification. The patients present with history of pain, dysfunction, weak grip, and on clinical assessment, we see subluxation of the shoulder sign. The palpation is painful, and this test is really painful when performed on the patients, the grind test. One has to be mindful of other etiologies which can have similar or nearly similar presentation, especially decurrence tenosynovitis. Carpal tunnel can be seen in nearly 50% of the group, and then non-unions, arthritis of the radial side. And one also has to be mindful of any neck pathologies. Now, coming on to the management of the first CMCJ arthritis, splinting, exercises, non-steroidal, corticosteroid injections, and activity modifications, all these have a role. When we have early stages, thumb spica bracing, non-steroidals, and injections. Injections are second line in mild to moderate disease. Hand therapy, it is really effective in reducing pain, avoiding fixed deformities, trying to strengthen the first dorsal interosseous ligament, prevents further subluxation, and this causes more stability of the thumb joint. Splinting in abduction reduces the subluxation and counters adduction contracture, and this in itself reduces symptoms in about 55 to 60% of the patients. 76% of the patients would have decreased symptoms in stage 1 and 2. Sorry. So combined splinting and hand therapy is shown to be effective in nearly 70% of the patients, as this study by Berber showed over nearly 7 years follow-up. There's a systematic review which again confirms that physical therapy does really make a big difference in managing pain and restoring strength and functional outcome in patients with first CMCJ arthritis in their early stages. Steroid injections, they are effective, and they are quite effective in early stages of the arthritis. But as the arthritis progresses, nearly only a quarter of the patients would get benefit. Different studies have been published about various injection regimes and with different comparisons between steroid and hyaluronic acid or placebo, and all all of them have shown some effectiveness. When we compare steroid with the hyaluronic acid, the only kind of benefit hyaluronic acid offered was more grip strength and pinch strength after 3 months. But again, the evidence, if we look at it, is quite equivocal. This is the systematic review from 9 randomized controlled trials, good patient numbers comparing corticosteroids to hyaluronic acid, saline, dextrose, and the evidence is equivocal. PRP, yes, there are promising results from PRP as we've seen in tennis elbow and other conditions, but also recently there has been a randomized controlled trial published comparing PRP to corticosteroids, and the benefit PRP has is longevity. While as corticosteroids are effective up to 6 months, the PRP has shown better lasting effect up to 12 months with pain scores and patient satisfaction, including quick dash scores. Now, coming on to the surgical treatment of first CMCJ arthritis, it depends on the radiographic stage, the patient symptoms, and also the patient's age and occupation. I'll be discussing about trapeziectomy and ligament reconstruction. Then my colleagues will be discussing the rest of the other interventions. So trapeziectomy, we perform it through a dorsal or a Wöhler-Wagner's approach. One has to be mindful of the different nerve structures around there, especially the branches of the superficial radial nerve. Any neuroma in these is quite painful for the patients. Trapezium is excised, and then FCR tendon is used to create a sling, which is to effectively prevent any proximal migration of the metacarpal. The patients go into a Wöhler slab. They're seen at 2 weeks' time for removal of sutures and then put in a splint for further 6 weeks. There are different techniques of doing the ligament interposition and ligament repair and reconstruction. We can use K-wires. We can drill a hole into the metacarpal and then use the FCR as an interposition. Some people do use palmaris as an interposition. So again, the same technique, the excess of the FCR tendon is used to fill the gap, which is created as a result of trapeziectomy. Suspension arthroplasty, effectively putting a suture between the FCR tendon and APL insertion. It acts as a hammock and prevents any proximal migration of the metacarpal. Now, there are different techniques have been described, and Nottingham group by Tim Davis did this study, and they followed up the patients, and they found out that there was no difference between whether you do a simple trapeziectomy or you do any ligament reconstruction or tendon interposition as far as functional outcome is concerned. Nowadays, even tension suture buttons have been used to prevent this problem. But again, there is an element of cost, and there are no prospective randomized controlled trials to look into their effectiveness. In the earlier stages of the disease, earlier stages of this, we can do a volar ligament reconstruction, again using the FCR tendon to reconstruct the anterior oblique ligament. Post-trapeziectomy instability is a problem. It's not seen in many cases, but when it happens, it is a difficult problem to manage. And one of the options to manage this would be to cause a fusion of the first to the second metacarpal. And this can be achieved through different ways, K-wires, screws, or even using plates or staples. We looked into the outcome of this in our study, which was presented a few years ago from Wrightington. And more than 50% of these united at 5 months post-procedure. But this is a difficult problem, and when a surgeon is faced with this, intermetacarpal fusion is a reasonable option. Besides this, a first CMCJ fusion is an option for especially manual laborers who cannot have a dysfunction thumb when it retropulses as a result of trapeziectomy. The other option which we can do, which corrects the deformity and also corrects any carpometacarpal subluxation, is an osteotomy of the first metacarpal. So that was it. Now I'm going to hand over to Onur for the second bit of presentation.
Thank you, Jagwant. So if I share my screen.
Shall I stop share now?
I think it allows me to proceed.
Okay, great. Are there any questions in the meantime? Nothing.
Nothing in the meantime. We'll keep an eye on that.
Yeah.
So, Jag, would you mind confirming that the presentation is live?
Yes, it is.
Wonderful, thank you. So good evening again, everybody. So this is the second presentation this evening, and I'll be covering some intermediate type of interventions such as thumb-based arthroscopy, something called a Cartiva, which is a synthetic cartilage implant, as well as thumb CMC joint distraction. So again, the plan for this section of the talk, we'll go over the indications, the procedures themselves, some touch upon the rehabilitation, patients can be informed as to what to expect, and some of the outcomes, and we'll try and make this as evidence-based as possible. So as Mr. Singh has touched upon, there are non-operative and operative options to manage thumb-based arthritis, starting off with very simple non-operative procedures, and then advancing onto the more surgical type of options. I've presented this as a treatment ladder, and this is very personal and also specific to the patient, tailored to the patient. I've tried to indicate where some of these particular options may fit in, for example, CMC joint arthroscopy before metacarpal osteotomy, and maybe Cartiva prior to a trapeziectomy. We've touched upon the Eaton and Litter classification, just a very brief reminder. These options that I presented are very much for the earlier stages of arthritis, to preserve joint motion and to maybe avoid the more bigger procedures such as a trapeziectomy and thumb joint replacement. So starting off with thumb-based arthroscopy. Personally, I tend to use thumb joint arthroscopy for very early stage degenerative changes, such as the Eaton and Litter stage 1, where there may be an element of synovitis. Now, the challenge is capturing a patient at the earliest stage, as they may possibly themselves present often late, and manage their symptoms independently. Again, personally, I tend to perform an arthroscopic debridement with this procedure, performing a synovectomy and, more importantly, a thermal capsular shrinkage, and I'll touch upon this in a second. There are more extended procedures are also performed, but I don't tend to perform these in my practice. So the aims of a thumb joint arthroscopy would be to debride the inflamed synovium, which provides pain relief, a denervation of the capsule, which again provides pain relief. The thermal capsular shrinkage, again, as mentioned earlier, as being probably the more important element of this procedure, which improves stability. And I'll explain the mechanism of that in a second. One can also remove prominent osteophytes, which reduces impingement and again enables pain relief. So the thermal capsular shrinkage, this aims to improve stability, and the mechanism of this is the application of heat up to 60 degrees using a probe such as the one shown in the slide, leads to unwinding of collagen fibers and subsequent recoiling of these fibers in a much shortened position, hence tightening some of the laxity in the capsular ligamentous structures. It initiates a fibroplasia and scarring, which again contributes to the stability. By application of heat, some of the small sensory receptors in the capsule is also blocked, which reduces the pain. The difficulty, the importance of this procedure is that immobilization is required for about 6 weeks afterwards, as the strength of the heated collagen decreases initially and then returns to normal over the 6 to 12 weeks after the procedure. Hence, immobilization is required to maintain a sound and stable joint. In my practice, I tend to get plain radiographs as one normally does, but if I'm suspicious of early grade osteoarthritis, I tend to get an MRI scan. There's a series of images displayed here on the slide, and it's essentially grade 1 changes that I would be looking for, as grade 2 and 3 changes are not proven to be as responsive to from arthroscopy. What happens in the earlier stage, grade 1, there's often distension of the joint because of synovitis. So seeing that on a radiograph followed on with an MRI scan helps make that diagnosis. Briefly, the procedure is minimally invasive. The portals are shown here in green, the 1R and the 1U, which is either side of a couple of important tendons in the anatomical snuff box, in particular the abductor pollicis longus and the extensor pollicis brevis. One has to be careful of certain important structures around the area, but carefully performed, the risks of the procedure are very low. Again, a quick reminder here of some of the ligaments around the CMC joint touched upon earlier on, but importantly, the anterior oblique ligament labeled AOL and the posterior oblique ligament labeled POL are what can be seen within the joint within arthroscopy, and these are the ligaments that we try to tighten through the capsular shrinkage intervention. Taking a step back, it is often these ligaments that are attenuated through the pathological processes that go on and contribute to CMC joint arthritis. The procedure is very similar to one would perform either a wrist arthroscopy, but instead slightly altered. A gentleman called PC Ho from Hong Kong has popularized a lot of the techniques around the wrist as well as the smaller joints of the hand. And procedure can be performed under local or regional anesthesia. A small scope is used, and some surgeons are now using the Arthrex nanoscope, which is even smaller than 2 millimeters. And then these are the typical findings of a normal joint. As mentioned earlier on, some of the ligaments can be seen from within the joint. Above MTC is the metacarpal side of the articular surface, and below is the trapezial side, and AOL is the anterior oblique ligament. The FCR crosses the base of the joint as well, which is often why it's used for ligament interposition procedures. So again, in a more pathological joint, these are the types of features that one can see. Again, A is the metacarpal side of the joint, and B is the trapezial side. C is the inflamed capsule, and D again here inflamed synovium. This slide demonstrates small osteophytes that can appear. This is on the deeper aspect of the joint, which can be effectively removed, thus minimizing impingement and hopefully pain. So a simple procedure, which doesn't take long to perform with small risk. The postoperative regime is then initially a plaster for a couple of weeks, and then immobilization in a thermoplastic splint, such as the one shown, for a further 4 weeks. One can then start free range of motion from week 6 and strengthening from week 8. I would allow patients to begin full weight bearing from week 12. So in terms of outcomes, I tend to find a third of these patients have a sustained relief following the procedure. One third improve but then have early recurrence, and a third have little benefit from the procedure at all, and an escalation of treatment is required. So more specifically, as mentioned earlier on, PC Ho published a paper looking at a case series of their patients. Of note, they had a large number, but a variety of different stages, and they followed patients up for around 59 months on average. They found no difference in the motion or strength after the procedure, but excellent or good pain relief in 50% at 2 years. It's important here that the improvement was maintained up to 2 years. There was a poor outcome in 23%. Another group, Fourier, who had an age-matched control versus a surgery group, they performed a simple debridement and a synovectomy and no capsular shrinkage, but they found a significant improvement in the visual analog scale pain scores, the DASH outcome score, and pinch strength. And finally, True, who performed a retrospective study of their patients with stage 1 and 2 arthritis. Again, for quite an extended follow-up period. They performed the capsular shrinkage and had patients in a plaster for 6 weeks. And they also found significant improvement in the visual analog score pain, for pain and pinch strength, as well as range of motion only and flexion. So that summarizes FUM CMC joint arthroscopy as a one option for treating early onset arthritis. The next option is the Cartiva synthetic cartilage implant. Now, the Cartiva is a synthetic hydrogel polymer, a polyvinyl alcohol and saline mix, has similar properties to contact lenses. It's been used in the first MTP joint for hallux rigidus for a lot longer than in the thumb. It maintains joint motion, and the implant we use in the thumb is 8 millimeters in diameter. An example of it can be seen in the diagram. In performance testing, it has mechanical and physical properties similar to native cartilage, high biocompatibility and very low or no toxicity as proven by FDA testing. It has a very low wear testing profile as well, tested in simulations of walking as it was used in the Foots First. This procedure, more extensive studies of this procedure has been performed from Derby, the Pulver Taft Hand Centre, where I learned the procedure, and now they're on to more multi-centre prospective studies. So they've performed their phase 2 multi-centre prospective studies, and they're performing more extensive studies at the moment. They have data of 49 patients at 12 months with very good outcome scores. They'd noticed a significant reduction in pain at 67%, which is greater than a LRTI, which is a trapeziectomy and a ligament reconstruction using either FCR or other tendons, or a simple trapeziectomy. Key pinch strength was had improved by as much as 100%. Tip pinch strength over 100%, and grip strength improved by 82%. Their functional improvement with a quick dash score, a lower score is a better functional outcome, had reduced by 46% at 12 months. And as mentioned, they're now performing a comparative study with trapeziectomy to look at more of a direct comparison to more established techniques. They're enrolling patients at the moment. So key questions that one may have regarding this implant. Again, a lot of these studies have been performed in the foot. In the motion study led by Glazebrook from the US has shown that the implants last almost 90% at almost 6 years. They found potential risks with the implant as being persistent pain in a proportion of patients. They had 1 infection out of their 152, and other complications that they found was things such as implant subsidence or occasionally a foreign body reaction, which was interesting, as the FDA studies found that there was low toxicity with the implant. So in my practice, an ideal patient would be one which has a stage above a 1, which would be a grade 2 or possibly a grade 3 osteoarthritis. Patient in this radiograph here is a stage 3 arthritis, which is probably pushing the limits of the implant. They'd have to be refractory to conservative treatment measures. They'd require good metacarpal bone stock, as the implant is embedded into the metacarpal here. and you'd want to avoid the procedure if there's osteoarthritis in the more proximal joints between the scaphoid and trapezium. So this is a patient who had arthritis and underwent the procedure. He was a 64-year-old male, right-hand dominant carpenter, had only very short-term relief from injections. The next slide demonstrates the operative procedure. It's performed for a similar incision as one would do a trapeziectomy or otherwise. The markings here indicate the incision in the capsule, which is a small flap which is raised. Again, you can see the arthritic surfaces between the trapezium and the metacarpal. A small recess is created for the implant, and then the implant is inserted. And you can see here kind of a small shiny implant, which is then distracting the joint and avoiding the roughened articular surfaces rubbing against each other and causing pain. The next slide shows a patient, again, the same patient at 4 weeks. Because he was slightly more advanced, I had to tighten his capsule, hence his motion hasn't quite returned yet, but this is him at 4 weeks. And his radiographs, again, demonstrating the distraction of the joint. He was comfortable, but quite tight. If it was an earlier grade arthritis, one wouldn't have to tighten the capsule so much and would enable more motion. So rehabilitation, I think I'll skip the research protocol and go on to more of the evolved protocol. Typically, patients only require a bulky dressing for the first couple of weeks. And then after the couple of weeks, once the scar is healed, wound is healed, one can begin scar management and begin then a strengthening regime at around the 8-week period, maintaining just joint motion prior to the strengthening regime. Around 12 weeks, patients can then begin full weight bearing. So the advantage of this procedure is it's minimally invasive, it's bone preserving, has high biocompatibility with good early outcomes as shown through the studies at the Pulver Taft Hand Center. It doesn't then preclude later conversion to a trapeziectomy or a CMC joint arthroplasty, which will be touched upon by Mr. Jepson later on, who has a huge amount of experience with this. So the final topic then is CMC joint distraction. So it's a procedure which is evolving and it's quite new. It's developed on from knee and ankle joint distraction procedures. It's thought to improve cartilage, the status of the cartilage by, number one, unloading it, reducing the mechanical stress, and hence allowing the chondrocytes to recover and heal. The evidence, I suppose, the evidence at the molecular scale is quite low, but some studies have demonstrated a reduction in certain proteinases. The MMP is a matrix metalloproteinase, which has been shown to be responsible for the evolution of osteoarthritis. So reduction in this enzyme has been seen in rat models, as well as reduction in interleukins. And this interleukin-1 in particular has been found to be decreased following this procedure, and this has been felt to be responsible for the pain component of osteoarthritis. So one would use it in patients who are refractory to conservative treatment, and typical indications would be grade 2 or 3 osteoarthritis. The procedure is performed using a small joint distractor with fine K-wires that are inserted into the metacarpal and the trapezium. 3 millimeters of distraction is dialed in, and this implant is kept on for around 8 weeks. The paper noted at the bottom, and the data from this paper is one of the earliest publications demonstrating some of the advantage of this procedure. So this was an early study with only a small number of patients, but followed up to 1 year. And again, this has to be taken with some consideration as to the small numbers. But what the group found was an improvement in the visual analog score, the functional outcomes according to DASH and the Michigan Hand Questionnaire. They did have one superficial pin site infection, which was treated well with antibiotics. They noted that grip strength improved, but only marginally. This is a procedure performed by one of our colleagues, Mr. Ali Noorani, in a 71-year-old patient who was keen to avoid more advanced surgical treatment such as trapeziectomy and failed conservative management. And the procedure was performed on the left thumb joint, and these radiographs demonstrated before and after after the procedure. I'm just going to come out of this, and I've got a video. Let me just share this. So this is with the patient a week after. So that was a thumbs up at week 1, and then this is after the implant had been removed. So coming back, so that was a patient who'd been followed up by Mr. Noorani and had what seemed to be good early outcomes. So again, another option in the armamentarium of treating thumb-based arthritis. But in summary, we've touched upon thumb CMC joint osteoarthritis, arthroscopy, and the early stages of management of the early stages of the disease, with 1/3 having sustained relief, 1/3 with improvement but early recurrence, and 1/3 little benefit. And then the Cartiva synthetic implant, which is at 1 year has had some very good results. And finally, this thumb CMC distraction, which is a procedure which may allow cartilage healing, and it's in very early stages. Thank you very much. I'll hand over to Mr. Alistair Jepson, who will talk about the final topic, which is thumb joint replacement. So I'm going to stop sharing. Let me see. As you should be able to take over now.
Is that working?
Looking good.
Great. Thank you very much for those two enjoyable talks. And my talk leads nicely into those two, just following on really from other options for treatment for slightly more advanced arthritis. There will be some overlap inevitably in what I'm saying and what's been said previously, and in terms of treatment and the different grades that have been discussed as well, whether it be grade 2, 3, or 4, and there is some overlap, things that can be done. But joint replacement, or effectively is a total joint replacement I'm going to mainly talk about, is a relatively newer procedure, and it's one that's gaining quite a lot of traction and had some very good results. So I'll introduce that to you. First of all, we always thought that when I was a trainee that trapeziectomy was one of the first operations that was described and had been done for years, and that was the only ever option that was permissible. However, looking back at the literature, in fact, a arthroplasty going back as far as 1930 was one of the first operations done, whereas trapeziectomy was described in 1949. And then you'll see 1960, there's some silastic implants that were being used as well, and they've been used to various other parts of the body as well. These had some promising short-term results, and I'll talk about those shortly. The design, however, evolved in 1970, and that's roughly the same time that Sir John Charnley in Wrightington came out with his total hip replacement. And if you look at the design of the implants on the top right of the slide there, you'll see there's a number of similarities between those implants and what a hip replacement would look like. I mean, typically the thumb X-ray tends to be turned upside down, so it's the opposite to what a hip looks like, but it's otherwise a very similar implant. And so the first evolution was a fairly standard implant, but then as the years went on, there was some modularity introduced to those implants, really in the early 1990s. So modularity means you've got different size stems, you've got different size necks and different size cups. And rather than being cemented, which had caused some problems with the first designs of the implant called the de la cafetière, they became uncemented as well. And the second generation implants have got various names: Arpe, Ivory, and Maya. And some of those are variations of those implants are still around. These are some of the literature for that, what we term second generation anatomical implants, the uncemented ones, and published results up to 10 years for some of those implants. And the survival rates were pretty good, anywhere between 87 and 96%, which is good, but of course we're always striving in orthopedics for better. And the problems particularly with those implants were that they loosened and they sometimes dislocated as well. So modifications of that procedure were introduced. I'll come back to those in a second. Going back to trapeziectomy, there have been problems with this, and all of us who've operated on these are well versed with the fact the recovery is long, and the patients are not guaranteed to get back the same quality hand function that they had prior to their arthritis, or even before they had their trapeziectomy. And often the issues tend to be with weakness of pinch and weakness of grasp. And sometimes we look at X-rays as well, we see the thumb subsides into the space where the trapezium is removed, and sometimes it also subluxes out to the side. Now, that doesn't always lead to problems, but if there are problems, one tends to see one of those two. Secondary joint instability, much less common, but I've mentioned a few of the things that have been described. So prior to going on to the third generation implants, I'll just show you a few of the other things that have been attempted, and these are various forms of hemiarthroplasty, which I've shown a few illustrations there. And these are this particular group is termed interposition arthroplasty, where a bit of tissue, sometimes it's a pyrocarbon ball or a little bit of metal, is put into the space. And these look, at the time of surgery, like a good idea. You've got some mobility that can move around the joint, you're preserving the anatomy. But the problems were with these, that if they failed, they could quite spectacularly fail, and the implants could dislocate or loosen. Here's another design of the hemiarthroplasty, sort of a cup and ball phenomenon on the right-hand side, and then what's regarded as a more anatomical shaped implant with a sort of representing the base of the metacarpal with more of a sort of saucer shape there. These are some of the failures from those implants. They either wore, they dislocated, or the ball could pop out. So this brings us on to what I want to mainly talk about today, and that's the third generation implants. So what has changed between the second and third generation is that there's an extra surface for mobility of the articulation. And again, this mirrors some of the work that's been done with hip replacements. And if you look at the top right slide there, you'll see the red and blue lines, which identify the two different surfaces which move. So you have a metal cup and then a plastic ball on a metal head, and they articulate within each other. So what that means is that the forces are shared across two surfaces, and there is also a greater degree of mobility of the move that can occur as well. And there's an illustration of there the difference of range that can be obtained. So that has an obvious advantage for the thumb, which is an extremely mobile joint. And you want to be able to reach your thumb across towards the base of the little finger, and that requires a lot of movement and also quite a lot of rotation to then also be able to rotate round and pinch against the index finger. So hence why this tends to be, as a joint replacement, the ball and socket joint seems more successful. And if you've got more mobility and less loading through the bone, then the implant in theory should last longer. Now, given that these implants came out in about 2010, some of them described in 2014, we haven't yet got long-term results. So that's the only caveat, but we have to start somewhere with these implants, and I'm being honest and open and frank in that respect. Here are two particular implants that are currently used in the UK. On the left-hand side is an implant called the Touch, and on the right-hand side, an implant called the Maya. Both are from French companies, and the designs are pretty similar. I'm not going to say identical because I don't want to get in trouble from the manufacturers, but they are pretty similar, and the origins have come from similar places. There's a picture of the Maya, the standard implant, and then the dual mobility implant, showing how similar they look. The stems are porous coated titanium stems, and the sockets, again, titanium with a polyethylene liner. And for the Touch, those were first put in 2014 as dual mobility, and the Maya from 2015. Predominant surgeons who've extolled the virtues of these are the French surgeons who put a lot of these in. And indeed, it was to France where I went to learn how to use these implants. I'll talk about that in a second. Not everyone's ideal for this implant. Certainly very severe end-stage arthritis, it's not appropriate. You have to have a sufficient bone in the trapezium to be able to get the implant in. If you've got arthritis of the STT joint, the adjacent joint, and that's symptomatic, then there's no point in replacing the CMC joint if you can have persisting pain from the STT joint. So in that scenario, you probably would do trapeziectomy. Heavy labourers, debatable, but I think you have to counsel them that if they put a lot of load, do a lot of work, high risk of dislocation, high risk of loosening, and that may not be the best option for them. A fusion is probably a better option. The other thing about this operation is you pretty much always counsel a patient that if you had a very difficult trapezium and you weren't absolutely certain you could get the implant in, the patient's consented for a more standard trapeziectomy as an alternative. So as always, preoperative consenting is vital. So 2018, I went to France, and not long after that started my surgery. So I'm one of the first surgeons in the UK to start doing this, and my experience now of the implants is about 35 total implants I put in now. You've seen some images already, the sort of approaches that can be done for trapeziectomy, and also for a volar approach, dorsal and volar approaches there. I tend to do the volar approach, which is marked up as number 2 here, but equally people are putting in the implants in through a dorsal approach. It doesn't really make a major difference. It's a short incision, significant soft tissue dissection around the base of the metacarpal to get everything loosened, all the ligaments freed, but minimal dissection of the trapezium to preserve the blood supply so that that uncemented implant can bond in. And use X-ray to make sure that the implant is correctly seated, because you're only going to get one opportunity to get the socket in the right place, and you don't want to get that wrong. There's options with with the implants to different size stems, so you will trial these out to make sure you get the appropriate stability of the implant on table, again using X-ray. The basic principles of the approach tend to do an osteotomy to cut the base of the metacarpal first, and then ream up the metacarpal, put a stem in there as a trial stem, then go on to the trapezium, pop a guide wire in the center, check with X-ray in the right place, and then cannulated instruments to make sure you ream over that, and then usually 2 or 3 different size cups that you can put in. So anywhere between 4 and 6 stems available, depending on which manufacturers you use, and cups between 8, 9 and 10 millimeters. Here's an example of a finished implant in place through a small incision. You can see the stem just sitting out of the bone, just marginally, the neck there, and then the plastic sitting inside the titanium cup. You can see the angle of the polyethylene there, and that gives you demonstrates that there is this dual mobility surface that I talked about earlier. Quite simple rehab. I mean, I started initially when I felt I ought to put patients in plaster, but actually one of the very first patients I operated on turned around and turned up with the plaster and said it was causing irritation, didn't like it too heavy, so I ended up removing it, and I haven't gone back on to putting a plaster since then. Allow them comfortable movement as pain allows from pretty much day one. All my operations have done have either been a weight block or have been general anaesthetic. I haven't done any local anaesthetic yet, but that's something for the future. Wider weight local anaesthetic tourniquet might be an option. They do then get splints, as shown there, again, as per the other implants that you've seen from Onur and then really return to sports and function depending on that level of activities fairly quickly. Obviously, something like cycling might be back in 2 months, something more physical like tennis and golf might be more like 3 months. The touch implants have been available now for a total of 7 years. To give you some context, there are something like 15,000 cases being done worldwide, mainly across Europe. So my small numbers, 31 of the touch and 4 now of the Maya, are small insignificance, but it's a big series, and I am prospectively collecting data with a view to publication as well. One minor complication only in that period, and that was into square veins, which settled down with an injection. And I'm not going to show you my figures at this point in time because I think it's too early to say, but the patient satisfaction is very high. I will just show you a couple of patient videos to finish up on. So this is the first patient who has got what looks probably stage 2 to 3, probably 3, osteoarthritis at the base of the thumb. She's young, so 46 years old. She's right-hand dominant, this is her left thumb, and she had a 3 to 4 year history of pain. I treated her initially with non-invasive or minimal invasive surgery with injection, some initial pain relief, but wasn't very long lasting. You can see a small osteophyte present there as well. And here are x-rays following that thumb CMT joint replacement, and then a short video I'll just show you, which was her 5 weeks after surgery.
That's what it is.
So it's a left thumb CMT joint replacement. You can see the x-ray there, and not asymptomatic thumb on the other side, but a good range of motion, and more importantly, free of pain. Second patient, slightly older, 58 years old, right-hand dominant, professional guitarist, had a 5-year history of pain, again, previous injections, and his x-rays, as you can see, predominantly left-sided arthritis, with some on the right side, but not as bad, and his intraoperative x-rays and his post-replacement. For purposes of time, I won't show you his video because it's a little bit longer, but it is available on YouTube channel, and it will, we can make sure it's published as well when we put the video online on YouTube as well through OS. The last patient, I'll just show a clinical result for her. This is just a few weeks ago. She's a 43-year-old lady. So this is a younger age group that I'm tending to do these in, where the bone quality is good. And she's 9 weeks post-replacement, again, quite glamorous with the old nails. And I'll just let that video play.
So lift the thumbs up towards the ceiling for me. Perfect, down you go. Hands on the side now, palms together. And lift the thumbs up towards the ceiling. Excellent, down you go. Palms facing up now. Lift the thumbs up towards the ceiling again. Good, and then reach across to the base of the little finger, as far as you can go on both sides. And how's the feeling over the thumb, sensation and touch over this area here?
Absolutely fine.
Good, and how are you finding the success of the implant? What were your symptoms before, and what are they like now?
Painful and very restricted. Absolutely incredible now. I've got no pain.
Fantastic.
And the movement is amazing.
Good, and your left side's fine, isn't it?
Yep, absolutely fine.
Good. I look forward to seeing you back in 6 months with a further x-ray.
So my indications really for the surgery are patients who failed non-operative treatment with injections, with physio, with rehab, pain relief, etc. Patients with younger age group with good bone stock, who want to maintain good function, who want to get back to activities quickly, are typical of working age, I've got incomes to I might be self-employed, want to get back to work quickly. I've been very pleased with the results and continue to use this currently. So thank you very much.
Thank you, Alistair. Yeah, once again, kind of great series of results, and I think you'd agree that patients seem really happy not being immobilized for long periods and not and being able to get back to their normal day-to-day activities earlier. Is that something you'd agree with?
Absolutely. There are 2 or 3 operations that I do in the upper limb which have just revolutionized patients' lives as far as I'm concerned. So, carpal tunnel release, trigger finger, and definitely the third one would be a basal thumb replacement. The recovery is outstandingly quick compared with a trapezectomy, where really most of the time at 6, 7, 8 weeks, the patients are just starting to almost just starting to use their thumb, whereas it's sort of the other video I could have shown you, the guy was playing guitar 2.5 weeks after his surgery. So there is a huge difference. And when you talk about people's livelihood at stake and typing keyboards or doing driving, they get back to work much quicker. So,
there are a couple of questions on the chat box. There is one from Saida Shahid, that are these implants available on the NHS?
So yes, they are. There are some regional restrictions in terms of whether the CCGs approve them, because they're a relatively expensive implant, but it is actually the HRG codes and tariff are for a trapezectomy and a thumb joint replacement are relatively high, and the implant is certainly covered within the cost of all of those. So it was initially an issue when I first started 4 years ago, but it's not an issue now, and it's the same implant I would use on the NHS as I would use privately. And
how do you think that denervation compares to using an implant?
So we haven't obviously touched on denervation. I know that Derby, the pull taft unit in Derby, is a strong believer in denervation. There's no doubt that of all the operations we do, we make a surgical incision. Some of the benefit from that operation may be from a denervation. However, where you've got limited range of motion due to some sublux joint or some instability, then a denervation is unlikely to improve the patient's range in that respect. So you have to look at each patient individually and decide what's the best treatment. But certainly a grade 3 arthritis, I don't think Derby were doing denervation for those. Again, it tends to be the earlier grade arthritis.
There is another interesting question. How do you find patients get on when they have instability, hyperextension of the metacarpophalangeal joint? Lauren finds that they tend to lack CMC joint extension and spans.
So certainly any sort of hyperextension deformity at the MCP joint is not a contraindication to doing a replacement. I might potentially consider putting a wire across that joint for someone for a short period if they have got significant hyperextension. But so far I haven't had to do that, because I think as you rebalance the thumb and get the tension right in the CMC joint, that seems to take care of the MCP joint on the whole. But I would consider a K-wire and immobilization of that joint if necessary.
There was initially a question to all the panelists about the steroid injection. Sorry, Onur, you wanted to add something? You can.
Just very briefly, I think, Lauren, definitely much more of a problem with when you're performing a trapeziectomy, because you can't quite reproduce as well the mechanics at the CMC joint after performing a trapeziectomy, despite doing a tendon interposition or using the FCR and weaving that around the base of the metacarpal. I think that becomes much more of an issue in that scenario. But as Alistair's mentioned, the CMC joint replacement reproduces the mechanics around the thumb base a lot better. The tension in the joint, it becomes probably less of an issue.
I think definitely the instability becomes a very big problem, and joint replacement would kind of take care of all of that problems also. There was another question to all of us panelists about the steroid injection, Alistair. How many times would you recommend that for a patient if it's effective in your cases, and Onur to yourself?
So personally, I do tend to try the non-operative measures first. So the physical therapy, splintage, and injection. I then base further injections on the patient's initial response. So if I perform one injection, the patient has sustained relief for several months, approaching a year, I would be happy then to perform a second injection. If the last injection provided no real long-term benefit, then I would then steer away or move up the treatments ladder. So I'd really tailor it to the patient. Patients respond well, continue maybe the injection type of treatment. If it stops working, then I'd recommend escalation, but I wouldn't repeatedly inject if it wasn't working for long periods.
Do you think PRP is going to be part of your treatments you offer now?
I think looking at the data that is appearing on PRP around the smaller joints, I think it may become more of an option. So again, I tend to base it on very much evidence-based, and as that's emerging, that will possibly be an option for us.
Great. Alistair, your thoughts on the steroid injections, how many times you offer them, and about the PRP?
Sure. PRP I don't do. Steroid injections, it depends really on the duration of success of the first injection, and often personal circumstances for the patient. Sorry, I missed the other replies, so I logged off, but we know that the steroid injection has some detrimental effect on the cartilage, so you have to discuss that with the patient. I'm going to say anywhere between 2 and 4, but it's not a fixed amount. It depends on the success of each, and usually advise the patient there's a law of diminishing returns for each injection.
Are you careful now, because of your joint replacement, if there's a patient who will be a prospective candidate for a CMCJ arthroplasty, how many times you offer injections to them, especially steroids? They could cause some attenuation of the capsule.
Unfortunately, that's not an issue with the capsule, because the capsule isn't something you have to really think about too much with a joint replacement. You pretty much excise it. The stability comes from the replacement itself, and it's all about doing a really comprehensive joint release to prevent any impingement with movement. So it's not an issue. Obviously, I wouldn't do one in close proximity to a surgery, but it doesn't make a particular difference to the number I would give.
Great, thank you. Any other questions? Anything else to discuss? I think.
Great.
That's it. Over to you, Onur.
So yeah, thank you again. Thank you very much, everybody, for joining us, and thank you to Mr. Singh for opening us up with the more traditional options. And then what I provided then was some options for the earlier stage arthritis, and then Mr. Alistair Jepson, who clearly has a wealth of experience with joint replacement. And so hopefully what we've provided you all with is a treatment ladder, and an option for the different stages of the condition. And again, what it does highlight is there are a multitude of different operations, and again, it has to be tailored to the individual patient, their demands, their needs. And once again, these talks will be available on the orthopedic specialist website, YouTube website, and I've put a link on the chat there as well. So thank you to panelists, thank you to everyone attending tonight, and to hopefully enjoy the football if you're that way inclined.
Thank you.
Thank you.
Bye-bye.